السلام عليكم. الله يعطيكم العافية. سؤالي للدكتورة بالنسبة للأزمة. دكتورة في بداية المحاضرة قلتي إنها توصل stage تصير not reversible. When can we determine this and يعني يا ريت لو explain more about it because I'm asthmatic I'm worried.
Okay. No, it's all about pathophysiology. Over time, the recurrent attack is gonna go and do scars in your bronchioles, and that's what's happened. And when we call it, it's become irreversible, because every inflammation is gonna leave its effect in the bronchioles, right? And over time, that's what I mean. Because of the scars and everything, and it's become fibrous, that's when it's become irreversible. That's it. But it's well known. The asthma is the only disease that when you give the treatment, symptoms is going to improve immediately. And when trauma improve immediately, that means it was only simple asthmatic attack, and you discharge them all. That's it.
Could it become COPD or no?
No, it's different, totally different. Okay. It's not really, no.
So in an emergency, why do they say the last thing you want to do is to intubate an asthmatic patient? Is the last thing you want to do is to intubate an asthmatic patient?
That's going to be a long story. So asthmatic patients, usually when they reach the last stage, okay, you give them all their treatment, there is no improvement. What's happened is usually they are tachypnic. So when you are tachypnic, okay, that's mean you are washing CO2. There is a lot of changes going in your body, dehydration through the respiration, and you will have, you are washing CO2, there will be acidosis, at the beginning alkalosis, and then when he's becoming lethargic, and he is tired, he cannot continue breathing at that fast rate. At the beginning, we say that he may reach even 50. Okay, per minute, because of that. And then he will become tired, go slowly, 40, 30, 20. He's gonna retain CO2. That's the only thing, the only patient. When you see CO2 normal, you get scared, because it should be low because of the tachypnea. So again, all these changes are gonna happen through his body. And when you go and intubate him, you stop his breathing. When he was breathing as 50 or 40. Okay, imagine yourself a very machine is working hardly, and you suddenly stop that machine. What's gonna happen? Okay, it's gonna be retained. He's gonna be in a shock. It's gonna be in stress. Okay, because you stop his respiratory drive. Okay, this point is critical. That's why we're always afraid to intubate a patient. I don't mean.
No, I think this is the point, is that once you reach to the extremis of bronchial asthma, then the situation becomes very difficult. You know that the patient's compensatory mechanisms have been exhausted. You don't have much of a room. The patient is usually hypercapnic, bradypneic, probably hypoxic, and bradycardic, have used all muscles, excess accessory muscles, have used all of the energy he has. He's air trapping. So the complexity of intubating these patients is quite difficult, and you have to take into account the procedure itself. So intubation and RSIing these patients becomes a very highly risk procedure, and the likelihood of these patients developing cardiac arrest soon after intubation is very high, due to the changes that occurs to the hemodynamics and to thoracic pressures. You don't want to reach that point. You would like to try to avert intubation and reaching to the point where these patients are really, really sick. Okay, once you put them on a ventilator, you end up you risk developing pneumothoraces, air trapping, cardiac arrest, and
the situation of the patient himself.
It's the hemodynamic changes and the respiratory changes and the changes with the thoracic pressures that makes the procedure itself risky. The consequences of the procedures are quite risky, and it's a very, very difficult situation. hopefully none of you guys will encounter that. I'll just add two novel treatments which are had been used in the past. One of them is the Heliox. So that changes the turbulent flow in a very narrow airway into more of a laminar flow. So it changes how the airways, channel flow of air into these tight lumens. NO can be also used, but this is also has been used in critical care facilities, ICUs, but it hasn't been used in the emergency department. And in terms of potassium, I would like to add is just to keep in context in terms of what is the deficit of in hypokalemia. So let's say if someone drops his potassium by 1, so if we say that the lower cutoff is 3.5, and you find out that the potassium level is 2.5, the body deficit, the total body deficit of potassium is about 370 milliequivalent. So you have to take that in account in terms of replacement. And the other thing that I would like to add, Ala Muhammad, just make sure that yes, you can give IV potassium, but the bioavailability of PO potassium is equally the same. And so you can replace potassium by mouth and by intravenously, as long as you make sure that the potassium is above 2.5, and then you can spread out the rest of the deficit over the course of the 24 or 48 hours, every Q6 or 8 hours. So that's a little bit of an advanced concept, but just make sure that, yes, the potassium is low, but there's a huge body deficit that you have to also replace. Heliox, which is which is a helium. It's a mixture of gases, helium and oxygen. Depends on different preparations. 80-20, so 80 of Heliox and 80-20 and 20% of oxygen. Sorry, it's vice versa. But the issue is that by developing these mixture of gases, you end up providing the patient with low oxygen content. So it improves the flow, or changes the turbulent flow into laminar flow, but at the expense of delivering oxygen.
Yeah, two questions about asthma. First one, should I start CPAP before magnesium and epinephrine?
Okay, so that's a very good question. Non-invasive ventilatory strategies, in terms of whether it's a CPAP or BiPAP, they are not considered cornerstone of treatment of bronchial asthma. For the most part, they are salvage therapy close to mechanical intubation. So you would try to avoid non-invasive ventilation as much as I can. The key concept behind non-invasive ventilation is that it improves recruitment, so it improves alveolar recruitment. It provides PEEP, so it counteracts the auto peeping that occurs because of the air trapping. So the patient would have lower threshold in terms of inspiration, so it assists inspiratory effort. But when you read the guidelines about using non-invasive, it hasn't been established. And there are not a lot of studies that looked at using non-invasive ventilation as a methodology or a method of ventilation. We oftentimes use it just before intubation, hoping that by putting the BiPAP, by assisting the patient, we will avert a more serious procedure, which would be the mechanical ventilation and the RSI. Unlike COPD, which is an established modality of treatment. There is no question about it. There has been a lot of RCTs, clinical studies that have looked at it, and we know that it changes mortality. To the contrary, we don't have that evidence in bronchial asthma.
Second question about ketamine, does it make a difference, or you just keep it like a last
ketamine
chance?
has been used in multiple situations. The classical teaching goes that you use ketamine as a choice of induction agent because it causes bronchodilation at the expense. But you have to keep in mind that yes, ketamine causes bronchial dilation, but it also increases secretions. And ketamine in itself, it's a dissociative agent. So what it happens is that you avert respiratory depression. And with these patients, you would like them to have respiratory effort as much as you can. So by choosing ketamine, you make them breathe on their own. Now, the other methodology of using it is that it has been used at low doses, so 1/3 of the induction doses, to try to calm them down. Because what happens with asthmatics, when they become severely ill, they breathe rapidly. They're anxious, they're frightened, they can't breathe, they feel they're suffocating. So by giving that just gentle sedation or gentle subdissociative dose, you take that edge out. So they relax and they're able to breathe.
But is it true that some physicians say when you give the patient ketamine, prepare the patient for intubation?
That's it. So you have two situations. You either use it as an induction
But
agent,
you already know that you
or
cannot
you use
intubate
it
the
as a
patient.
subdissociative before induction. So none of these strategies have been proven with evidence, with solid evidence. But this is at least with the limited literature quote at this point in time. Any other questions?
Okay, يعطيكم العافية. Question about the asthma. When we reach the state which we cannot, the general treatment, which is steroid or the beta adrenergic, what's not have any benefit. So we have to move to the magnesium, and this case we called status asthmaticus, or it's something else.
Want to take that one?
Yeah. So it's the same. Whenever the patient you see in severe patient, you give him the first back-to-back, and you give him the second one, and you don't see any improvement. Okay. Yeah, we go now in the field of status asthmaticus. You don't stop the Ventolin, and you continue giving the Ventolin even when you move to the other modality. The main treatment for asthma is the Ventolin, okay, which is the beta agonist. The other modality is just gonna help Ventolin to improve the effect and give a small effect as a side at the side, okay, to improve the effect of the primary drug, and that's why we use it. But status asthmaticus is that the patient, when he doesn't become responsive to the main treatment, and his severity doesn't improve.
The problem with status is that the definition is not written in stone. Okay, so I bet you will not find two resources that agree on the definition of status. But what we can tell you is that, مثل ما إيمان قالت, is that if you implement appropriate treatment based on the severity class of asthma, and that treatment strategy does not reverse the process, and the asthma continues to progress, then that is status asthmaticus. So if you have a mild to moderate asthma, you have implemented your management, you've started your management, and no matter with whatever you've done in terms of adequately managing these patients, they continue to get worse, and they move from mild to moderate to severe, and then all the way to severe or life-threatening. Then I think that's status asthmaticus. Any other questions? Okay, so I think we should be closing now. So on behalf of Best of EM group and all the physicians and the organizers, we thank you for being here. I hope it was a fruitful day. I know it was a long day. We have decided to go with small talks, multiple talks, as much as we can, so that we can enrich your experience as much as possible. We also welcome your feedback, as this is the first ever Red Flag series, and we would like to do it in the future. We would like to repeat that experience in the future, so we value your feedback to us. So tell us what have worked, what topics you've liked, what topics you want us to change. And matter of fact, if you have any topics that you would like to hear about or to let us know, and we'll be more than happy to talk about them in the future, inshallah. So thank you for being here. Have a good evening. I know tomorrow is Ahad. Allah ya'inkum. I don't know if you have any comments.
جزاكم الله خير دكاتره، ما قصرتوا. طبعا اغلب الدكاتره اليوم جزاهم الله خير، كثير منهم بوست نايت، بعضهم مواصل من امس ما جاء، طلع من الدوام جاء دايركت هنا، واللي جاي من سفر، او الدكتور اللي جاي من سفر، فيعني وضعهم كلهم تعبانين، ومع هذا حرصوا انهم يجون جزاهم الله خير، وقدموا لنا المحاضرات الله ما قصروا، فنبي صفقه منهم الدكاتره.
يلا have fun وروح البيت. شكرا. See you.
بالنسبه للشهادات بنرسل الفيدباك سيرفي. رجاء كل واحد يكتب اسمه كم مثل ما يبغاه بالشهاده يكتبه بالسيرفي. كل البوينتس عبونا نايس سجستشنز مثل ما قال الدكتور عبد العزيز. ومنها راح تجيكم الشهادات PDF على الايميل ان شاء الله. بالنسبه